Okay, so welcome everybody to this new session of the ERN-EuroBloodNet topic on focus dedicated on thrombotic microangiopathies. As you know, before starting, I always share with you the information on the program and the house rules. So as you know, this program is developed with a collaboration between the European Reference Network on Rare Hematological Disease and the French National Center for Thrombotic Microangiopathy, the CNR-MAT. And it's a cycle of sessions of webinars that consist of 15 sessions that are accredited by 11 continual medical points of the European Board for accreditation in hematology. So if you want to receive and submit this accreditation, it's very important that you have correctly wrote your name and surname in the Zoom platform. And also at the end of the session, you are going to receive a survey. And so please answer it in order that we can track your presence and give accreditation. Some other quickly house rules. So this session is recorded because it will be implemented in our e-learning platform and educational channel on YouTube, where you can find the past webinars also. So if you are not comfortable with it, please switch off your camera. And then your micro will be muted during all the presentations. At the end of the presentation, there is the Q&A sessions, and it's up to you if you prefer to write the questions in the chat, or you can raise your hand and you can unmute yourself and ask directly the question or any comment, feedback, not only questions. I mean, every thought you would like to share. So today we are going to talk about management of atypical hemolytic uremic syndrome with the Professor Menne. So he's the head of the Department of Nephrology, Vascular Medicine and Rheumatology at the Klinikum Siloa University. I hope I've pronounced it properly. You will correct me. Since 2009, he has been involved in the treatment of patients with atypical hemolytic uremic syndrome and has treated more than 120 patients. He analyzed also the German 2011 Escherichia coli hemolytic uremic syndrome outbreak and has collected the data from the 95% of the affected patients. Since 2019, he has collected with colleagues from Cologne all data of German TTP patients treated with Ravulizumab. He's also co-authored of the German guidelines on diabetic nephropathy and has been involved in many studies related to resistant hypertension. Finally, he has published more than 100 articles in peer-reviewed journals. So, Professor Menne, I'm very honored to pass the floor to you. Thank you very much.
Yes, thank you very much. Welcome. My talk is today about atypical hemolytic uremic syndrome. I mean, this is just conflict of interest. Of course, Alexion, Sanofi, Genzyme, and Ablings, these are companies that treat patients with thrombotic microangiopathies. What I'm going to talk to you is about my personal experience and what I've learned from individual cases. It's always in rare diseases because you do not see them as often like heart failure that you see every day on the ward. So you have to look at these individual cases And there you always find some unique features, but that will help you understand the disease better. So it's important always to look at these patients and look closely and to find new interesting informations. Then I'm going to talk briefly about Ravulizumab, because eculizumab, everyone will know about it. It's now on the market for more than 10 years. Ravulizumab is new on the market. And then I'm also going to talk about discontinuation strategies. I mean, it has been always a hot topic because eculizumab and now also Ravulizumab are extremely expensive drugs. I mean, this we observe often in rare diseases, but still they are really on the high end of the spectrum, of the price spectrum. I'm actually going to talk to you about the first patient that I treated with AHUS. And honestly, in 2009, I was not even aware that such a disease was existing. I had heard about HUS and TTP, but I wasn't aware that there is something, an entity called atypical HUS. And this was actually the patient that I encountered. He had actually just received his 4th kidney transplant. When he was 6 years old, he went on to dialysis. And then he had 3 kidney transplants from the age 6 to age 12. And all the kidneys he lost within 1 to 2 months because of recurrence of the disease. And then when he was 12 years old, everyone said, we are not going to transplant him again. And so he was now already 27 years old. And so he asked him for another go. And actually we decided to do it. And I mean, honestly, we didn't not even do plasma exchange prior to it. And so we gave him a kidney transplant. It was in January. And then he had initial dysfunction, but then the kidney was actually coming and it was working quite nicely. So creatinine was falling down to 200, 250. But suddenly he had a sharp rise in his creatinine. Of course, he was biopsied and we found a hemolytic uremic syndrome. I mean, he had received tacrolimus. So what we did then, we started with plasma exchange, and actually everything was getting better. So we discharged him again. But a couple of days later, he had another creatinine rise. And also you can see there's some fluctuation in his platelets. Platelets is green, not really going down very far, only down to 100. And his LDH is also a bit fluctuating. LDH is only 330, so not really very high, but still elevated. And then he came back. He had another biopsy. Again, we found a hemolytic uremic syndrome. We plasma exchanged him. We sent him off. He came back. In the meantime, we had switched him from tacrolimus to sirolimus because we thought, well, perhaps it's dangerous. Nowadays, we know that sirolimus is as bad as tacrolimus. At the time in 2009, everyone was thinking that only tacrolimus can cause hemolytic uremic syndrome. So we restarted him with plasma exchange. We stopped it and it happened again. And then we said, this is stupid. I mean, he's never going out for more than 2 to 3 weeks and he has a relapse of the disease. So we continued him on permanent plasma exchange. What was good at the time, that we actually participated in the first study with eculizumab randomized study. And so he was actually the first patient in Germany randomized into the phase 3 eculizumab trial. And this happened then in October 2009. What is then actually interesting, because he had already, we had stopped sirolimus and tacrolimus, so we continued just with mycophenolate mofetil and very low prednisolone dose, because we thought eculizumab has also some immune modulating effect. And this is actually very low immunosuppression for someone who is now his first forced transplant. What you can see now, actually creatinine was beforehand always fluctuating. Even under plasma exchange, you see there's a lot of fluctuation. Always this goes up and down. And then afterwards with eculizumab, suddenly it became very stable and even it was dropping. I mean, you can see over the years until 2011, it was dropping. And now he has taken this drug now for 12 years and his creatinine is still at 1.7, 1.8. So still very good kidney function for someone who has already now a transplant for 12 years. So this was actually my first patient with AHUS. What is also interesting, and this is important, Here you can see the TMA. This was beginning of March. And just 8 days later with plasma exchange, it was completely gone. You do not see it anymore on biopsy. Then 14 days later, it was back again. Here you can see it was affecting the arterioles and the glomeruli. We plasma exchange them, and it was gone again. So if you treat TMA quickly, then histological changes will come and go very quickly. So if you start treatment and you do a biopsy, you might miss it because it's already gone. So you should always aim to try to get it as early as possible. Otherwise, you might miss the diagnosis if you have already commenced with treatment. And why is eculizumab working? I mean, what is now known, and you have, if you're familiar with it, complement activation is crucial. And there's a concept that there's some underlying complement genetic mutations or predispositions so that you get perhaps some complement activation, and this is when you have genetic defects. But even if you have a genetic defect, usually it's not sufficient really to get a TMA. You need something additionally. And this is the second hit. It can be an infection like COVID is nowadays discussed, or other things, or a tumor or chemotherapy, or something else that's obvious. Sometimes you will not even be able to identify. And then you will come over a certain threshold. And of course, this threshold is different from patient to patient. The idea is that if you give complement inhibition with eculizumab or C5 inhibition, that you elevate this threshold so far that even if they have a very severe trigger and a severe genetic mutation, they will be unable to reach this level where they get enough complement activation to get the disease. And it's now proven, I mean, there's a lot of study out. I mean, eculizumab, we have evidence that if you treat it earlier, some say even before, within 7 days, I'm a bit questionable. I think 14 to 21 days after making the diagnosis is usually sufficient. You can wait with plasma exchange for 5 to 7 days and see if it's working. But you shouldn't wait too long, because then there might be some permanent damage that you will be unable to repair. And I will just tell you here with this patient, because I said they will be unable to repair. This was a patient that it was in 2012. This patient had a dialysis-dependent acute kidney injury. It was a young woman, and on biopsy, it looked like malignant nephrosclerosis. And they contacted me then 6 months later because the question if she would be eligible for a transplantation. And they talked to me about this, and I said, well, have you actually tried with this young woman already treatment? And they said no, and I said we should definitely try eculizumab. So we started eculizumab in February 2013, and as you can see, her creatinine on dialysis was 6.5. Within 2 months, it dropped to 2.6. We stopped it, and then it dropped further down to 1.4. This patient now has a GFR of 40, and she had then this for many years. I haven't seen her for the last 2 or 3 years, but until 2019, she had creatinine of 1.4. So brilliant. And we did, of course, also genetic mutational analysis, and we found a C3 gain of function mutation. So she really had a complement mutation. What I hadn't mentioned is one patient initially had no genetic mutations that we could detect in 2009. Another very interesting patient, also a woman. I mean, women always get more often TMAs, about 70% of TMA patients. This is independent if it's Shiga HUS, EHEC HUS, Shiga HUS, or atypical HUS or TTP. Always women get it more frequently. This was actually a case that was interesting because she had acute kidney injury when she was only 32 years old. Her father had hemolytic uremic syndrome and was even on dialysis for 7 years and died. And so she was then actually had to receive plasma exchange. For some reason in this external hospital, they gave only 2 doses of eculizumab, then they stopped it. So she had an immediate relapse within 2 months. And then she was transferred to us. So we continue treatment, and what was actually interesting, even under treatment, she had a short episode of heart failure, probably due to HUS. And this is the only case where I had really a breakthrough through eculizumab, that I had a recurrence of HUS under treatment. It was solved easily. We just reduced the frequency to weekly for a short time, for 2 weeks, 3 days, and then everything was fine. And actually we found a CFI mutation. Probably the father had the same mutation. This is the one reason why I show it to you, that you can have breakthrough even with eculizumab, but this happens very rarely. In her case, she had a complete recovery. But what is even more striking, and this I've seen now in a couple of patients. So you can see this is the GFR, is the blue line, so kidney function. And you see even this is here when she had this kind of relapse, the first relapse, and this is when she had the second relapse. And you can see that her kidney function is getting better and better and better. Every year, it's still improving by 5 milliliters GFR. And this even after 5 years. And this is striking. Something like this you do not usually see if you have someone with a kidney disease. So this means that there's some repair happening. And I think the explanation is quite easy. Hemolytic uremic syndrome is at the end not a kidney disease, it's a vascular disease. You get damage to your vasculature and therefore you get less oxygen supplies. But the kidney has primarily not a defect, it's just not enough oxygen. If you now repair it and you do not get another endothelial damage, then the kidney can repair, and this just will take time. And so this is always something to consider. And initially, she had also high proteinuria. This is something that you often see. Often you see 2 to 5 to 7 grams of proteinuria. I've never seen more than 10 grams, but 7 grams I've already seen with TMA. And what you can see then, that the proteinuria is also getting better. As longer we treat, as better it's getting, and now it's even not even a microalbuminuria. Now it's below 30 milligrams per day, and she was coming from 4 grams. So this is really very good. So what are we now doing? If we have the patient where we have a suspicion, then we look for LDH, platelets, HB, acute renal failure, and neurology. And if we have 3 criteria, we think about it, and then we start treating these patients. What is also important, you have thrombotic microangiopathy, you look for other causes like sepsis or lupus or malignant hypertension. And if you do not find this and the kidney is involved and the kidney platelets are above 50,000, I will always go for a kidney biopsy just to prove that this is truly TMA that you see. And then, of course, we start with plasma exchange. We look for ADAMTS13 antibodies, and this you will all know. This is, but it's very important that you measure these parameters, especially factor H antibody. I have actually missed 2 cases because initially I always thought factor H antibody is something that only happens in children. I have now seen a couple of patients in adulthood where they also had factor H antibody. If they have Shiga toxin, and this is what we've learned from the German EHEC outbreak, you do not have to give eculizumab. It's not working in this condition. What you have to do, you have to give antibiotic treatment. In the other case, you wait for plasma exchange. You get your ADAMTS13 back. If it's TTP, then you do different treatment. And yeah, there you had already talks. But if it's AHUS, then you really should severely consider eculizumab, especially if they do not respond quickly to plasma exchange. And often platelets and LDH is getting better with plasma exchange, but the kidney function is not recovering. If the kidney function is not recovering, then I would be liberal with giving these patients eculizumab. What is now Ravulizumab? Ravulizumab is at the end just a modified eculizumab. It's the same company, Alexion, who has produced it. And what they have modified, they actually changed only 4 amino acids within eculizumab. 2 amino acid chain changed in the FC region and 2 in the variable region. And what is actually striking, and I wasn't aware of this mechanism, and this is the first drug that was modulated so, they changed the FC region so that it's actually dependent, the binding to this region is pH dependent. And in the lysosome, the pH is lower than in the circulation. So what now happens that in the pH 6, it binds to the FC receptor. And then actually it dissociates from the complement and it's recirculated to the surface. And at the surface, at the pH of 7.4, it dissociates from the FC receptor and then the antibody is going back into the circulation. The complement that is still in will be destroyed as a C5 and just will be destroyed. And so you just recirculate, so it's very ecologic. So you have a recycling of an antibody, and by doing this, the half-life is going up from 11 days to more than 50 days. So you suddenly have only to give this drug every 8 weeks instead of every 2 weeks. So this is something that is actually very interesting. Eculizumab, however, will be destroyed, and this is shown here because it does not bind to the FC receptor. What is also different from eculizumab, in adulthood, you have different dosages depending on the weight. And in children, you have also different dosing. And here you see it's not in the eculizumab. You have always to look a bit what dose you have to give. Here it's clearly described. What is really important, both drugs are extremely expensive. But you see that Ravulizumab costs per year about 200,000 euro less. This is at least the German price. But I believe that in the other European countries, it will be not much cheaper. Perhaps slightly cheaper, but not much. What is also important, eculizumab you can monitor very nicely and very easily. You just have to measure CH50. CH50 does not work perfectly in Ravulizumab. It works in about 80% of patients, but in some patients you will get unreliable results. So you really cannot measure if your system is completely suppressed. Therefore, you would have to measure free C5. And to measure free C5 is difficult because there's more or less no standard laboratory that will offer this test. So this is a disadvantage that you really cannot monitor if your complement system is sufficiently suppressed. This is only possible with eculizumab. How is it working? It's actually similar to what we have seen with eculizumab. You get a good TMA response, whatever you look at, platelet count, LDH, improvement of creatinine, you will see it. And if you compare the data to the eculizumab data, it's roughly the same. I mean, this you can see in this table. The only thing that was a bit worrisome, in the Ravulizumab patients, you had 3 death cases. But this was probably due to a selection problem of these patients, that there were patients with sepsis included into the trial who had actually sepsis and not really pure TMA. And these patients died actually. But still, it's something that you should know about. What was also a problem, and I wrote an editorial to this article, that if you look at the data, that it was especially in Asian centers a problem. So Asian centers, the patient in Asian center had a much lower response rate. You can see the response rate was only 15%, whereas in the non-Asian centers it was 65%. And in the non-Asian eculizumab, because eculizumab was not performed in any Asian center, there you had a response rate in the studies of 85%. So this is actually very similar, but why are the Asian centers so much worse? And the explanation was actually probably quite easy. In Asia, they are not so familiar with the diagnosis of aHUS, and they do not have so much experience with treating. So it took them very long to make the diagnosis and to make a decision to treat. Actually, more or less all of their patients, or the majority of their patients, 10 out of 13, were only started after 28 days of aHUS already. So, and I've told you before that early treatment is important. So you shouldn't wait too long. And we have also data from France, early data from 2013 to 2014 who have already suggested so. So this is actually important. Because when you look in Asian patients who were treated in non-Asian centers, in European centers, there's a response rate was also 80%. So it has nothing to do that Asian patients will be less responsive. It has probably something to do with the treatment algorithm and that they are not so experienced with this disease. The question is, I've told you it's extremely expensive, and therefore always everyone was thinking about, do we have to treat really every patient lifelong? I mean, 600,000 euro per year, lifelong treatment, you can imagine you will reach 10 million or 20 million lifelong costs for this drug. And there had been already a Cardigo controversy conference, Discontinuation, about discontinuation, and this was published in 2017, and Goodship is the primary author. Goodship was actually the first one who identified that complement factor H is the culprit of aHUS. So he is really one of the fathers of the diagnosis of aHUS. And there they made a bit of a differentiation if you have an adult patient, a child, or a transplanted patient. Then they said that a child, you would really want that they have already completely recovered their renal function and they're at least 3 years old before you consider it. In transplanted patients, they said, well, you should be careful. And when you stop it, they said you should monitor it closely. And in summary, they said it's at the end of the day, it's an individual decision, duration at least for 6 months of treatment. But of course, this is also a bit artificial. I mean, there's no proof that you really have to do it. It could be also that perhaps 3 months is sufficient, but no one knows exactly. What they said that you should have at least for 3 months a stable kidney function. And I think this is important. I've shown you the case where the kidney function was still improving. So as long as the kidney function is still improving and albuminuria is continuously going down, you should not really consider doing it. It should be really stable. Or if the patients were already on dialysis for more than 4 to 6 months. And what is actually important, we analyzed all the official eculizumab studies together with Alexion, and there were all patients included from the studies with long-term follow-up data. And actually in this long-term follow-up, a lot of these patients also discontinued treatment. 42 patients had treatment periods where they were discontinued. And in a lot of these patients, initiation of eculizumab was required, of course, due to relapse. But in half of them, it was also not required. And this is what we analyzed, and we published this 2 years ago. And what are the findings? First of all, it was very safe. So we had really no safety issues, and I can tell you, I've given now so many infusions of it. I've never seen any complications, not ever even an allergic reaction. I have also not seen a single case of meningococcal infection, but of course it's still a risk. And we do not give permanent antibiotic prophylaxis. We just give initially, and we do a vaccination. But I have not seen a meningococcal infection yet. What also was seen, that the renal improvement that was seen initially was then sustained for many years. You can see it's more or less stable for many, many years. And this I can confirm that if they have not already a lot of scarring, that you will see then a very stable function. If they have already a lot of scarring and they come in with a GFR of 20, 25, you still see people who will continuously deteriorate and even go on to dialysis. So early diagnosis and early treatment is really important. When patients were discontinued, we looked at what are these patients. These were often patients who had already normalized their kidney function or almost normal kidney function. And they were often also closely monitored for signs of TMA and quickly started if needed. So they were closely monitored, these patients. And what were risks for relapse in these patients who were stopped? First of all, they had a 13.5 or higher TMA rate than the patient who continued treatment. And this were actually especially pediatric aHUS patients. So I always would also think if someone already gets the disease in pediatric time, they probably have a worse genetic background. who had identified complement abnormalities and history of multiple TMAs. So if you had already 1 or 2 episodes prior, then you were also more likely to get a relapse. And in the patient who discontinued, you see that the GFR was slightly going down. I mean, of course, it's difficult because there's a lot of fluctuations. The numbers were not high. It might be a suggestion that some of them have underlying disease and still losing some kidney function, but we couldn't prove it. And so we came to the following recommendation. And discontinuation of eculizumab, and this is in the abstract, with careful monitoring is an option in select patients with consideration of patient preference, organ function normalization, and risk factors for relapse, including mutational analysis, age of onset, and history of multiple TMAs. So this was actually our recommendation, and I think this recommendation is still true. What is important in May 2021 in Blood, there was the first prospective study published by Fakhouri, who was actually one of the co-authors also of this article. Fakhouri is really one of the leading persons in France who has done a lot of studies, and he published this study, nice study, where they did a prospective study where they stopped the drug. And what you could see, this were quite a lot of patients. There were 56 patients that they were included, and they had in the supplement in a nice table of all discontinuation studies. And when they put all these data together, they had in patients without a mutation or without a variant, they had a very low relapse rate of 3.5%. If they had a mutation, the relapse rate was about 46%. So this is actually a huge difference. And this is actually the same what we had in this prospective data. There in the without a mutation, there were about 6% with a relapse, and the rate was about 30 to 40% with rare variant. And of course, in 2009, when the studies were doing, we do not have a complete genetic workup. So it might be that actually the true patients without a rare variants actually have some mutations that are still not identified. And there was an editorial, and the editorial said that you should first wait for a complete clinical response, and then you look for a genetic mutation. And if they have no mutation, then the risk of relapse is low, and therefore you should discontinue, but you should monitor. And if there's no relapse, then you continue without medication. If there's a relapse, of course, then you receive C5 inhibition. If you have a mutation, they say actually you could consider doing it, but the risk will be higher, and you have to monitor these patients really very close. And especially if you have factor H mutation or C3 gain of function mutation or factor B mutation, I would not advise to do so. In factor E and MCP, the risk will be less likely, and often they do not get severe relapses, but also there are patients who will develop end-stage kidney disease. And coming back to the first patient, I told you that we couldn't find a mutation in 2009, in 2014. So we repeated it with next generation sequencing and MLP analysis. And actually what we found, he had a complete deletion of the final exons of CFH gene. And of course, we couldn't find it in Sanger sequencing because it was a deletion. And this explains completely why he had such a severe disease, because the crucial element of CFH was lacking in this patient on one gene. So this is actually a good explanation. So you should always do every 3 to 4 years in patients you find not a mutation, you should repeat the genetic analysis, because genetics is evolving quickly and the technique is getting better and better. So my own conclusion is, can we stop eculizumab in some patients? Yes. What we do stop it in dialysis patients when they're for 2 to 3 months and on biopsy they have still a lot of damage, then we stop it. When they have an outer mutation and with a full genetic workup, including what I just mentioned, and less than 2 hours with a stable kidney function for at least 2 to 3 months and no active renal hours manifestation, then we would also stop it. And definitely, if they have an anti-CFH antibody and this is in remission and so on, no antibody detectable after immunosuppressive treatment, I would also do it. Importantly, you have to measure then closely anti-CFH antibody to restart immunosuppression if the antibody is coming back. And uncertain diagnosis. As I told you, early treatment is important. So we are actually quite liberal nowadays. If we have a TMA and we believe that it's ours, that we start early on, then we have additionally, we get to see also the effect of the drug. And then after 4 to 6 weeks, we have the genetic back. And then we can make a decision after 6 to 8 weeks of treatment. Are we going to continue or not? And then we have some more information and this is helpful. What is important if you stop, especially if they have no mutation, it's not so important, but if they have a mild mutation, then you definitely have to do it. LDH, full blood count, creatinine, haptoglobin, and albumin creatinine ratio. There's some evidence, at least from own patients, that haptoglobin might be an earlier marker where you might detect it early that it is. There's also something that was interesting in the blood article. If you measure C5 to 9, these patients who had elevated C5 9 when they've stopped eculizumab have a higher risk that they will develop a relapse. So this is something also that is possible to do to identify these patients. So in summary, what have I learned from treating over 120 patients over the past 10 years? Always check for anti-CFH antibody. As I told you, I had missed initially 2 patients at the first presentation because we had done plasma exchange and we didn't detect it. Even after long-term dialysis treatment, renal function can recover. I've shown you this one patient, but the longest case that has been reported was for 18 months on dialysis, and then they started treatment and this patient recovered. If you have the suspicion that this patient has an HUS, you can start plasma exchange, but if they do not recover, especially kidney function, you should start C5 inhibition. TMA in a renal transplant might be a sign of HUS even when humoral rejection is diagnosed. I didn't show you cases, but we have seen it a couple times that there was humoral rejection, but they had also a bit of TMA, and then we treated these patients and we found that these people were responding and actually they had underlying mutations, even sometimes severe mutations. C5 inhibition can lead to a substantial continuous improvement in relief even after 1 year of treatment. So this is what I've shown you, and it's a couple of patients where they even after 2-3 years are still getting better. What is also important, many secondary tumors, including malignant, are complement mediated. This is a bit a tricky issue. Some people do seem to respond, some not. This is really very severe, difficult always to make the right decision if this patient now requires a complement inhibition or not. But what is also clear, there are some patients out who have no genetic mutation who can have a severe relapsing HUS. And it's very likely that some of these patients will have a mutation that is not identified yet, and where the gene is also not known yet. Probably we will identify then in the future other genes, and we will see. So that's all from my point, and I hope that we will have a lively discussion.
Thank you very much, Professor Menne, for your great lecture. So as always, I encourage the audience to write questions or raise their hand and also ask orally the question. So I can see there is one hand, Antonis Katamis. So please, you can.
Hello, I hope you can hear me. Thank you for the great presentation. I have a couple of questions for you. One is that I need to give you my experience. We have diagnosed a very young patient back 15 years ago with Atypical HUS, and at that point we didn't have the eculizumab available, and we asked the company, and we gave it in a off-label protocol. At that time, we started giving that on an intermittent basis, and what we did a dipstick and urine dipstick on a daily basis. And whenever we see that his hemoglobin start having hemoglobin on the urine, he came to the hospital and he got the drug. So in this way, whenever he had a crisis, within the first 5 hours, he will get the drug. And after 15 years, the child has preserved his renal function, and he's just using the drug once a year, maybe, and he can diagnose the initiation of the event very early with just the urine dipstick.
Does he has an MCP mutation?
He has a C3 mutation.
C3, even a C3 gain of function mutation. I mean, it's interesting. It confirms what Adesino has also said, that in children, you have one huge advantage. In children, usually they have a complete kidney recovery, and their hematuria and proteinuria is actually a good marker for detecting the disease. In adults, you often cannot use it, because adults usually have already some kidney damage when they come in, and they always have a bit of hematuria and proteinuria, and it does not completely disappear. So in children, you can really use the dipstick to monitor it. And Adesino has also done not a protocol like you, but they extended things only. They gave it to the people who had it, and they even stopped patients with CFH mutations. But then they got 50% relapse, and they detected, and they didn't do daily, but they did it at least weekly. And then they could find if they had a relapse, and then they restarted, and they found actually it was working. So this is a possibility, because it's often more, you need something like a trigger than to get a flare up, and then it's underlying, and actually nothing is happening because you are under the threshold. And then if you're under the threshold, probably you do not need it, because there's not continuous. In some people, you might have continuous damage, but in the majority, you have no damage or you have damage. And if you're under this one, you wouldn't need it, but it's difficult to identify it. I mean, if you have this kind in these patients that you can identify it with hemoglobinuria, you will know, oh, now I'm over the threshold, so I have to treat him. And then suddenly perhaps this second triggering event just disappears, so he will be under this threshold again and nothing will happen. So this is a very striking case. I've never heard about such a case. I think it's where you have done it really with daily dipsticking and then the guiding the treatment. It's a brilliant case. I mean, if you look at it financial wise, I mean, the patient is doing well. And if you would have treated them continuously, I mean, 10 years of treatment, I mean, this would be a fortune. You could buy a couple of houses with it.
Yeah. I just want to make a comment. I'm very impressed with the new drug, has a long half-life. And the economic studies show that it's 20% cheaper. But
yes,
in 4 months from now, the patent will be off. And we're going to have many different similar drugs. So apparently it's going to be, again,
I mean, it will be interesting. It will be interesting because now this generics will come to the market.
Yes.
And it will be interesting how much the price will drop. There will be some movement downwards. I don't know how far it will go. I mean, the companies I've spoken to, they haven't told me yet where they want to go with the final price. I think everyone is still hiding because, of course, it will be competitive. And this will be interesting to watch, but definitely the price will drop. And then, of course, we will have again the discussion. What is now, if he goes then with eculizumab or a generic eculizumab or Ravulizumab? I mean, then there will be a new discussion.
But we're not going to have generic for Ravulizumab. We're going to have only generic for eculizumab.
Yeah, of course, eculizumab. It will be then the discussion what you want to do. If you say, especially in some patients, I mean, especially if they're younger people, I mean, can you really say them every 2 weeks to get this kind of infusion? Or I mean, of course, they will prefer to have it only every 8 weeks. And there will be some discussion. Definitely, we will see this.
Yeah. Thank you so much.
Thanks also. Very striking case.
Thank you very much. So I'm collecting questions in the chat. I will go first with the first one I've received privately. I've just copy pasted it and I will read it, but I'm sorry as there are some codes. I don't know if I named them properly. So could eculizumab discontinuation be safely attempted in a 8-year-old boy, native kidney, with heterozygous CD46 C389 plus 1GA, likely pathogenic, incomplete response to eculizumab for first TMA episode, total treatment duration 5 months. He recently tolerated a 3-week interval between injection. Thank you.
I mean, this is more or less a patient. I mean, it's known that the MCP mutation will give you a higher relapse rate. It seems to be that the MCP mutation, or at least what we know from this, that they will have a less risk to develop end-stage kidney disease. So, I mean, it's possible to do this kind of relapse in a children. You should always do it like in the prior case, that these patients then closely monitor their own urine. So to detect that they have any kidney damage coming, so that you will detect it very early, because that you can really use then eculizumab or ravulizumab as rescue treatment. So this is, I think, something very important that needs to be discussed with the parents, because I mean, if they will not follow this rule, that they monitor it closely, you might endanger the boy. But if the parents are very compliant and the boy is also willing to do it, it's an option. And you can do it. And they have also shown this now in the French group. I mean, the majority, the big severe relapses is always with CFH, actually also C3 and factor B mutation, but especially CFH mutation. MCP, you can try, but you have to monitor them closely.
Thank you very much. So I will move to the other one. What to do if the response to eculizumab is suboptimal? Platelet count do not rise. The reticulocyte count is persistent, elevated, combined. Should we combine PECs followed by eculizumab?
I mean, this is actually in children, it's often plasma exchange is not given anymore, because you do go straight away to the first line treatment of eculizumab. In children, you have also the advantage that there's not so many secondary TMA forms that are a bit more complicated, and especially the secondary TMA forms are not as responsive as the ones like the primary HUS, where there's probably a complement mutation. So you must always, if it's an adult patient, you should always look if there's any underlying problem that is perhaps causative. And sometimes it could be also vitamin B12 or folic acid deficiency, but especially vitamin B12. Also, you must look also for drugs, especially other things, if this is the case. If this is not the case, then it's worthwhile to do plasma exchange, but you should only give them couple 5 or 6 treatments of plasma exchange, and then you should give eculizumab. It's not worthwhile to do plasma exchange and giving eculizumab, because you will remove eculizumab and then you have to substitute eculizumab. And then, of course, it's getting extremely expensive. So in such a condition, we would always do a couple days of pure plasma exchange, and at the end, we would give then eculizumab again. What I've seen in some patients, it took up to 4 weeks before I could really see a response, even when they had a complement mutation. This was the longest I've seen. So it was actually continuously rising for 6 weeks. And we always thought it's not working at all. We started with a creatinine of 3.5, and the patient was at 5.5 after 6 weeks. And we said it's nonsense to give it. But this patient had TMA in the biopsy. So we said we continue. And then this patient was actually dropping, and then it dropped down to 2 and remained on 2 for 2 to 3 years after a kidney transplant. So this was the longest where really before it took how long we could see the result. Usually you see it quicker. Usually you see it within 1 to 2 weeks.
Thank you very much. And a related question, would you consider to switch from eculizumab to Ravulizumab just because it's easier to get it every 8 weeks in a child with atypical HUS? Thank you, Elena Solomo.
Of course, I mean, we have more or less switched everyone from on long-term treatment from eculizumab to Ravulizumab. We still start with eculizumab because we can monitor CH50 and we have, of course, much more experience in the early phase. And especially in adulthood, sometimes you are not completely certain, is this now aHUS or not? And then you can make the decision quicker. And you can measure CH50 because sometimes you have patients who have a mutation in C5, and when they have this mutation, the drug is not working. So in these patients, you shouldn't give it at all, or it's not necessary to give it because it will not work. But this is only in the Japanese population in 1 to 2%, but in Europe there have been some cases. But we usually switch them to Ravulizumab. Of course, this is now new prices that will come. Of course, there will be some discussion if these patients need to be switched. It really will be also depending on the price. But presently, we still do it, and a lot of people find it much better than receiving a drug every 2 weeks. Especially, I mean, if they have a mutation and they truly have to give it for many years, and it makes a difference if you have the injection every 2 weeks. Also, you will destroy or you will damage the vessels on the long term, and then there will be less puncture, so you will have also some protection from the vasculature.
I think there are no more questions. So thank you very much, Professor Menne, for
Thank you very much also.
And thanks also to the audience. It has been a very fruitful Q&A sessions and interaction. Thank you so much.
Thanks a lot. Bye-bye. I just have to go to give another talk now. Bye.
Break a leg.
Good.
Bye-bye.
Bye.